So what I'm going to talk about today is frontal limbic neural circuit changes in emotional processing and inhibitory control following TFP. And just as an overview, the results that I'm going to present today have actually been published. They were published in 2016 in Psychiatry and Clinical Neurosciences. So for those of you that are interested in more detail, you can go ahead and check out the publication. In terms of my involvement in this study, I was fortunate to be a postdoc on this study. So the patients that I will be talking about today in terms of the assessments, I know them very well. And so I really do thank them also for their time and involvement in our project. So as we've kind of been talking about today, borderline personality disorder is characterized by self-regulation deficits and interpersonal difficulties, which leads to rapid mood alterations and also intense emotional and behavioral responses such as impulsivity, aggression, and parasuicidal behaviors. As we all know, BPD is also characterized by high utilization of psychiatric and medical resources. Yet, as Krista, I think, also kind of presented on, the neurobiology and treatment of BPD have received less attention than other psychiatric conditions with similar rates of utilization. So in terms of neurobiological findings in BPD, what do we know? fMRI studies that have probed emotional processing in BPD have identified reduced top-down regulatory prefrontal cortex activity and, as Krista mentioned, enhanced amygdala activity. Several studies have also found reduced anterior cingulate cortex, ACC, reduced frontal polar cortex, FPC, and reduced orbitofrontal cortex, OFC, activation in conjunction with increased amygdalar activity during negative emotional processing in particular. And this suggests decreased monitoring and regulation and increased reactivity in the context of negative emotional stimuli. So in terms of the negative emotional stimuli, research has found that BPD patients display reduced FPC and ACC activation in response to fearful facial emotions. And several studies have also found prefrontal cortex dysfunction and increased amygdala activation during negatively valenced picture viewing and fear-based tasks. In a study that David Silberswag and colleagues did, when comparing BPD patients to healthy subjects, frontal limbic dysfunction was identified in the posterior medial orbitofrontal cortex and the dorsal anterior cingulate cortex. And in particular, deficits in self-reported restraint of impulsive behavior was correlated with decreased posterior medial OFC activation, while negative affect was correlated with extended amygdala activation. So the neural substrates of symptoms associated with BPD have been investigated. However, the mechanisms mediating symptom improvement following psychotherapy for BPD have been less well studied, as Krista mentioned. And few studies have specifically investigated neural changes associated with psychodynamic psychotherapy in any clinical population, let alone BPD. And so for the study today, we're going to talk about transference-focused psychotherapy. So as you heard this morning by Dr. Otto Kernberg, TFP is an evidence-based treatment for BPD that was developed by Dr. Kernberg and his colleagues. It's a psychodynamic object-relational approach where patients are seen twice weekly for 50-minute sessions. It relies on the techniques of clarification, confrontation, and interpretation of affect-laden themes that emerge within the relationship between patient and therapist. And in a previous randomized controlled trial looking at TFP, DBT, and supportive psychodynamic treatment, TFP significantly reduced impulsivity, anger, irritability, and suicidality over the course of 1 year of treatment. So for the current study, what I'm going to present to you is some pilot work that we did to examine changes in the frontal limbic neural activation during the interaction of inhibitory control and negative emotional processing in BPD, in BPD patients who received 1 year of TFP. This was a within-subjects design, and we predicted improvements in neural functioning from pre to post-treatment. Specifically, we hypothesized decreased amygdala activation and increased medial prefrontal cortex activation from pre to post-treatment. We also predicted that baseline neural activation patterns in these particular regions would predict treatment response. So, like I said, it was a very small study, a pilot study of 10 women that were diagnosed with BPD. Their mean age was around 27 years old, and we diagnosed them with BPD using the International Personality Disorder Examination. You can see we also used the SCID to look at comorbid disorders. I only put up on the slide current comorbid disorders for this particular sample, mostly in the anxiety disorder range and substance use range. As well as comorbid PD diagnoses, we had 3 of our women also had comorbid histrionic personality disorder, 1 with avoidant PD, and 2 with narcissistic PD. 5 of the patients of the 10 were on psychotropic medication throughout study participation, and 9 of the patients were right-handed. So as I said, all patients received 1 year of TFP. The average number of sessions attended was around 76, 77. Again, remember, it's a twice-a-week treatment for 2 years. All of the therapists, we had 5 therapists in this particular study. They all had advanced degrees in social work, psychology, or psychiatry, and also had at least 2 years experience treating individuals with BPD. And all of our therapists were supervised by Otto Kernberg and Frank Yeomans and were rated for adherence and competence with TFP. In terms of clinical improvement on self-report measures, we were mostly, for this particular paper, most interested in 3 self-report measures: the multidimensional personality questionnaire, and here we were interested in constraint, the inhibition of impulsive behavior. We were also interested in the affective lability scale, which Krista mentioned earlier, as well as aggression on the overt aggression scale, which is a clinician-rated measure of aggression. All of our participants underwent the pre- and post-treatment scan. Average scan interval was 12 months, which was good. We did have a range, though, of 10 to 14. We had 1 patient who ended a bit early because she was moving to the Dominican Republic, so we needed to get her scanned. And then we had 1 patient who was quite difficult to track down at the end of treatment to get her scanned. In the scanner, the participants performed an emotional linguistic go, no-go task with verbal stimuli that contained themes that were salient for BPD. So, for example, the word abandon would be a word that would have some negative emotional salience for an individual diagnosed with BPD. Participants were instructed to perform a right index finger button press immediately after silently reading a word that appeared in normal font. This was the go trial. And to inhibit this response after reading a word in italicized font. So this was the no-go trial. Button press responses and reaction times were recorded. And then following scanning, we did look at word recognition and valence rating tasks as well, though I won't be presenting that. This is just what it looks like. So you can see the word abandon in that. I don't know, which one is the, do we think the pointer is the red button?
Yeah, the other separate.
Oh. So you can see here, right, abandon is in normal font, so you would push the button. Pitiful is in normal font, you would push the button. Over here in the no-go trial, abandon, you would push the button. It's in the normal font, but pitiful, you would have to inhibit. It's their no-go trial. So Krista also mentioned this is what it would look like in terms of acquisition, processing, and analyses. I'm not going to go through all of this. In terms of what scanner, we had a GE Cigna 3 Tesla MRI scanner, the 2-level voxel-wise linear random effects model. But really what I'm going to point you to is that the regions of interest for us were the bilateral posterior medial OFC, the ACC, and the amygdala. And planned contrasts of interest were examined as a function both of treatment as well as predictors of treatment response via correlations with TFP-related changes in scores on those self-report measures. Okay, so in terms of what we found, so probing the interaction of negative emotional processing and behavioral inhibition as a function of treatment. Compared to pre-treatment, our borderline patients showed relative increased activation in cognitive control areas, specifically the right anterior dorsal ACC, which is up here in A, and the right dorsal prefrontal cortex in B. We also had relative decreased activation as compared to pretreatment in the left inferior frontal gyrus prefrontal cortex here, and in the left hippocampus, which is also down here in D. In terms of probing clinical improvement following treatment and changes in neural activity, results showed improvements in the MPQ constraint, that ability to inhibit, correlated positively with left anterior dorsal ACC activation in A. Improvements in our affective lability scale correlated positively with left posterior medial OFC ventral striatum activation in B, and correlated negatively with right amygdala parahippocampal cortex activation here in C. And then finally, improvements in the aggression measure, the clinician-rated aggression measure, correlated positively with activation in the left inferior frontal gyrus. And then finally, the neural predictors of treatment response. These are our pre-treatment scans, so improvements in MPQ constraint negatively correlated with pre-treatment activation in the right anterior dorsal ACC, and improvements in the affective lability scale negatively correlated with pre-treatment activation in the left posterior medial OFC. Okay, so what does this mean? What we found in this very preliminary study, that treatment with TFP was associated with relative activation increases in emotional and cognitive control areas, as well as relative decreases in areas associated with emotional reactivity and semantic-based memory retrieval. TFP may potentially facilitate symptom improvement in BPD by improving cognitive emotional control via increased activation in the dorsal ACC, the posterior medial OFC, and the prefrontal cortex. The anterior dorsal ACC may also be thought of as a critical node for emotion regulation and cognitive control, and that the clinical improvements we saw in MPQ constraint and the relatively elevated anterior dorsal ACC activation at post-treatment suggests that TFP may modulate neural activation in this region in particular to improve behavioral restraint. TFP-associated amygdala effects were also found. As we know, the amygdala is critical for negative emotion, fear processing, and emotional memory, and that response to TFP was associated with decreased amygdala activation. This suggests that BPD patients were potentially able to engage in task demands with reduced negative emotional interference at post-treatment. And then finally, decreased left hippocampal activation was also found from pre to post-treatment, TFP treatment. And again, as we know, the hippocampus is critical for rapid encoding, consolidation, and retrieval of contextual effects or features. And hippocampal activation decreases suggest perhaps a reduced need for semantic memory retrieval in the context of negative emotion. The TFP treatment effects may be associated with top-down prefrontal cortex control over limbic emotional reactivity and semantic memory processing symptoms. And if you think to what Dr. Kernberg talked about this morning, TFP is designed to engage what we would call the patient's observing ego, the ability to kind of take a step back and to reflect and improved, and it also helps with improved awareness of negative emotions, and ability to integrate more realistic representations of self and other, thus, being able to enable more adaptive associations and more adaptive behaviors. As I said before, this is really a very small sample, so it's really very much pilot work. We do have a current ongoing study that will examine a larger sample of women diagnosed with BPD over 18 months of TFP. It's important to note that there were multiple comorbidities in this sample, as well as the 5 subjects who were taking psychotropic medication that was not held constant during treatment. This was partially controlled for by our within subjects design, but I also think it does represent a kind of more realistic picture of what treatment with BPD looks like in terms of comorbidity, in terms of the messiness and complications with medication. But overall, the results suggest that the dorsal ACC, the posterior medial OFC, amygdala, and hippocampus may warrant further investigation as potential biomarkers associated with clinical improvement following TFP. So thank you.